Hello everyone, welcome back. This week we'll be discussing sexual health as well as a little bit of sociology of sexuality. Jumping into this topic, first it's important that we understand what sexuality is. A person's sexuality is the combination of their sexual orientation, experiences of attraction, and sexual preferences. Sexual orientation is essentially the label a person might use to describe themselves. Attraction is the people or the types of people that a person is attracted to. That could be based off of things like the partner's gender, personality, interests, appearance, and so much more. And sexual preferences are the types of sexual experiences that a person wants to have. So what kind of sexual activities they might want to do, what types of things they like to do alone or with others, the types or the numbers of partners that person prefers to have, and so on. A really common misconception is that gender and sexuality are directly connected. That's actually not the case. Having a certain gender does not automatically make a person any particular sexuality. Just because a person is a man or a woman or transgender or gender nonconforming, that does not mean that they're automatically straight or gay or bisexual or any other kind of label. Those things can be connected, but they are, in essence, separate concepts. It's also important that we understand that sexuality is a fluid concept. So a person's identity, who they're attracted to, and their interests and preferences can change throughout life. That's very, very normal. There is nothing to be ashamed of in that arena. This is something that every person is exploring and learning about as they go through life. Bringing it back to the topic of our class, medicine or health and illness, medical sociology has spent a lot of time researching sexuality, and there is a long history of sexuality overlapping with medical research and the medical field. A lot of the time, sexuality has been fairly overlooked, particularly sexual orientations other than being straight or heterosexual. We've seen a long history of the pathologization of certain behaviors and identities, such as seeing transgender people or gay or lesbian or queer people as potentially mentally ill, as well as the failure to include AFAB bodies or those who were assigned female at birth in research up until fairly recently in the last handful of decades, as well as an overlooking of health concerns experienced by AFAB individuals. We also have seen a historical pattern of promoting one idea of what is normal, this idea that heterosexuality is what's normal, that being cisgender is what's normal, and that being monogamous is what's normal. Of course, we know through the field of sociology of sexuality that there is a lot more nuance to this, there are a lot more options, and that this idea of normal is a fairly harmful social construct. So, what medical sociologists do when we kind of blend these two fields together, we are trying to look at the whole spectrum of sexuality and health. All of those gray areas, all of that nuance. We are looking at LGBTQIA 2+, 2S+ identities, sexual activities and preferences, the intersections of positionality, sexuality and health, and so much more. This is a huge and ever-growing field. Sexuality, like other parts of our identities, such as race, ethnicity, class, disability, and so on, it is affected by the sociocultural context that we live in, the time period and the region that we live in, and all of those different factors in the social world. So, all of those social and cultural and often also religious trends and values can really influence what we think, what we believe, and what we do in our lives in regards to sex and sexuality. There's a lot of misinformation out there. There are a lot of perspectives that can be very limiting and often very harmful to people with certain identities or in certain communities. When this overlaps with medical knowledge or the field of medicine, we can see the social construction taking place in a way that, again, reifies this idea that there is a end-all be-all, quote, normal way to be in terms of sexuality or sexual orientation. Despite all of those sociocultural context factors, despite religion, despite the advice or common beliefs within the medical field, there is, again, a lot of nuance and a lot of gray area to sexuality and sexual health. So the perspective of medical sociologists on this topic is that there is nothing wrong with any sexual activities as long as every person involved is a consenting adult. That is the most important factor here. There's also this perspective that there is nothing weird or bad about being interested in things that other people aren't interested in, or not being interested in sexual activity at all. There are also a lot of people who have what we would call fetishes or paraphilias, and these are intense sexual interests in particular items, body parts, or activities that society might see as atypical or abnormal. Again, that social construction of, this kind of interest is normal, this kind of interest is not. It is all very fluid, and there's a lot of gray area here. Medical sociologists, we would also say that engaging in sexual activity or not engaging in sexual activity, these are both normal parts of the human experience. Everyone has different levels of interest and comfort and familiarity with these things, and so it is not a problem wherever a person falls on that spectrum as far as their interest and their comfort level with these topics. Now that we've covered a little bit of background here, let's get into the actual health and illness part of this lecture. We're going to talk about sexual health and safety. There are 3 essential topics in this arena. We want to be looking at consent, communication, and safety in general. So consent is the informed and enthusiastic agreement to participate in a specific activity. So informed being a person knows exactly what they're getting into. Enthusiastic meaning that there is no hesitation, that they are excited about that activity. And again, specific meaning that it is very clear exactly what activity, what kind of sexual encounter, what kind of behavior is being agreed to. It is not consent if a person is under the influence, if they were not asked for consent, if that person is hesitant or unsure about giving their consent or about what they might be agreeing to. It's not consent if someone is pressured or worn down, and that doesn't have to be in one day. That can be long-term, that can be short-term. It is also not consent if somebody says no, or if they do not say yes. If a person lacks that enthusiasm or clear interest, then that does not fit the definition of consent. And without consent, any sexual contact is sexual assault. One really important point when we're talking about consent is that consent can be revoked or taken away at any time. So if a person changes their mind, if they want to stop doing something at any time, if they liked something before but they don't want to do it anymore today, or if they agreed to something and then changed their mind, all of that is absolutely okay. That is built into the concept of consent. Consent can be revoked at any time. No person owes an explanation either for revoking their consent. Any person can do this at any time, and that is okay. It's also important that we recognize that all body contact requires consent. So this does not have to be just sexual activities. This can be other things like kissing, hugging, cuddling, or just touching someone, period. It is always a good idea to ask somebody ahead of time before any body contact to see if they're okay with that kind of body contact at that moment in that instance. Another important facet of consent is that consent is an ongoing process. So if a person is engaged in, for example, a sexual activity, then they should be checking in with their partner throughout that process. Consent is not just a yes at the beginning and then it's forever good. You need to make sure that you have that ongoing enthusiasm for whatever activities are taking place. It's also important to ask before changing things up, doing something new or doing something different. And it's very helpful to communicate what you are doing to another person. You can say something like, I'm going to do this now, insert whatever activity it is that you're describing, and check if that's okay. It's very important to show respect to the other person or people that you're involved with, be open and adjust to their needs as you go, and just really, be open-minded and listen. That ongoing consent really relies on that respect and open communication. When it comes to communicating about sex and sexual activity, this is really, really crucial to maintaining ongoing consent as well as respect and sexual safety and health. It's super important to talk with partners about what they want to do, what you want to do, and just have a very clear understanding of where that overlap is. What do you have in common? There are luckily a lot of tools in the modern day and age to help with these kinds of discussions. They can be difficult discussions, but you can figure out what interests you have in common with your partner or partners through doing things like there's a quiz online called Mojo Upgrade that will show you what both you and a partner agree to in terms of sexual activities. Or you can also Google this worksheet called the Relationship Anarchy Smorgasbord, which has some really great discussion starters and prompts to discuss what you do and don't want to include in your relationships. It is very, very crucial that you're on the same page as any other sexual partner about what is okay, what is off limits, what you like, what you don't like, and vice versa, what is okay and off limits for them, what they like and don't like as well. And finally, it's okay to be nervous if you're trying something new. If you have that informed consent and you know what you're getting into, you're excited about it, even if you're not quite excited, but you're willing and you're maybe just a little nervous, that is okay. That is normal. Again, communicating and respecting and just staying on the same page as your partner is going to really be what allows that safe environment and that sexual health and safety to be really robust. Speaking a little further on this safety piece, if you are ever in an unsafe situation, there is a lot of support that you can reach. Sometimes unsafe situations cannot be easily avoided. Sometimes they're unexpected, and these kinds of things can happen to any person. So we have some great resources at UCCS. The Dean of Students Office is very, very helpful if you're looking for support. You can also, of course, talk to your instructors. We do have to report any kind of major safety concerns to the Dean of Students Office, but that is for your own safety and well-being. We can get you connected with resources on campus and beyond. And of course, you can talk to any trusted loved ones in your life as well if you're looking for some support in your day-to-day life. I also have here a couple different phone numbers that are very helpful. There is the National Domestic Violence Hotline that you can call, the National Sexual Assault Hotline, and just a general crisis text line. If you don't want to talk on the phone, you can text home to this number here, and you can just text back and forth with a crisis counselor for as long as you need, if that's an easier communication style for you. Moving on to a topic that is, to a lot of people, the more obvious sexual health topic here, sexually transmitted infections or STIs. Any person who is sexually active or who plans to be sexually active, it is very important to get regularly tested for STIs. It is very easy to get tested. You can do this at most GPs or PCP offices, whoever your regular doctor is. We do also have STI testing and physicals available at the UCCS Wellness Center for any of our students. So it is very, very easy to get in with the Wellness Center and to get this testing done if you are sexually active. STIs also, they're just a normal part of being human. It's kind of like a common cold or catching the flu. These are just things that happen. There's a lot of shame and stigma in our cultural discourse about STIs, but again, they are a normal part of being human. There is over 50% lifetime prevalence of STIs. That means that more than half of people will have an STI at some point during their life. That is a lot of people. It's really important that we understand that when we talk about STIs as far as this very devaluing kind of language where we say, oh, I'm clean, I was just tested recently and I'm clean, that kind of language implies the opposite of being dirty, and that can be very stigmatizing for people who have long-term or incurable STIs. And I would urge you to kind of try to move away from that language. You can say things like, I was just tested and I don't have any active infections. That's a perfectly fine language replacement for that dirty or clean kind of language, because STIs, again, are just a part of the human experience. This is something that a lot of people will go through, and there doesn't have to be shame attached to it. There doesn't have to be stigma attached to it. It's something that can just simply be. While that stigma is something that we would like to eschew or move away from in our society for a lot of reasons, it is no secret that contracting an STI is something that can be very unpleasant for a variety of reasons, even the symptoms alone. So avoiding an infection is something that a lot of people are very interested in. And so there's a little bit of information about some very common STIs. These are some of the most common STIs that exist. There is the human papillomavirus, or HPV. This one is extremely common. It can cause skin warts, but a lot of the time it's asymptomatic. Frequently it does go away. A person's immune system can fight it off, but it can also, in some cases, lead to cancer of the genital regions. This is a primary reason why pap smears are very important for anybody who has that anatomy. If a person is assigned female at birth, getting pap smears regularly and checking for HPV as well as cervical cancer is really important to long-term health. But luckily, there is a vaccine for HPV. It doesn't cover every single strain out there, but it covers the most dangerous and the most common strains of HPV. So if you have not gotten the HPV vaccine, I would highly encourage that. That's something that can be really beneficial to not only your own health, but to other people in your life as well. There is also herpes, which is HSV, another virus. This can cause cold sores or genital sores. There are different strains for those different body areas. If a person does have herpes and has an active flare-up, it's important for them to avoid having sex with other partners during that time, even if the other partner also has herpes. That's a pretty common misconception that if both people have the same kind of herpes, that having sex during a flare-up is completely okay, but it can actually exacerbate symptoms for both or one partner, and that can cause a lot of discomfort. Herpes is not curable, but it doesn't have any long-term health concerns. This is not something that will ever be life-threatening or lead to cancer or anything like that. So if a person does have herpes, it's something that they just are going to be managing as a chronic illness lifelong. We also have syphilis. This can cause a certain type of sore called a chancre sore, a different kind of sore than a canker sore, very similar names there, but it is a particularly painful sore. The symptoms of syphilis can be very dangerous and very unpleasant. So if a person does have syphilis, they can be treated with antibiotics to get rid of that infection. And it's very important that that treatment happens early on after the initial infection. Gonorrhea is another STI. This can cause painful urination, genital burning, and a variety of other symptoms. This one as well can be easily treated with antibiotics, so if you ever have any of those symptoms, it's important to go get tested and then you can get that treatment. There's also trichomoniasis, which causes itching and genital redness. This one is not a bacteria, this is actually a parasite, so this one needs to be treated with anti-parasite medications, but again, it's a very easy treatment to access if you've gotten that test and that diagnosis of trichomoniasis. Sometimes you'll hear this one be called trich as well. We also have chlamydia. This is something that causes painful urination and genital burning. This again also can be treated easily with antibiotics. The symptoms of syphilis, gonorrhea, trich, and chlamydia, these are all fairly similar in a lot of ways. So if you ever have any of those symptoms, painful urination, burning, itching, redness, or any kinds of odors that are different than usual, for any person with a penis or people with a vulva, if you see any kind of discharge that is different than usual, if anything is really just significantly not your usual, then that's a good time to go get tested. Finally, here we have HIV, the human immunodeficiency virus. This is another incurable virus. This is something that a person will have lifelong as a chronic illness. This causes a variety of symptoms. There are a lot of different symptoms of the initial and long-term HIV infection. but long-term, it can harm a person's immune system and lead to AIDS or acquired immune deficiency syndrome. But luckily, we've had a lot of development in this area when it comes to medication for HIV treatment. In the last 40 years, this has come a long, long way, and so current medications actually can reduce a person's viral load to the point that it becomes undetectable on tests. And in that case, a person may not actually be able to transmit their HIV to another partner at that time. So really amazing medical technology, huge medical advances there. But this is just a little bit of basic information about some of the most common STIs. There's a lot more to learn out there, but in general, again, if you ever have any strange or new symptoms, it's very important to go get tested and talk to your doctor about that. When it comes to preventing sexually transmitted infections, the best way to know your status and to keep any of your partners healthy is to get regularly tested. Again, you can go to the CCS Wellness Center to get very accessible, easy, quick testing. You can also go to your GP or PCP, just your general doctor. Some of the other ways that you can prevent STIs would be through barrier methods. So these would be things like using condoms or dental dams. This can help prevent the swapping of fluids with a partner, because most STIs are transmitted through genital fluids, the anus, sometimes blood, sometimes saliva, generally body fluids that if we can prevent that swapping through use of barriers, that can be really beneficial towards the prevention of STIs. For anyone who is at a higher risk of HIV infection, so that could be gay or bisexual men or transgender women, we do see higher rates of HIV amongst these populations. If you are in those populations, or if those are your identities, then you can get PrEP medication, which can be something that you take regularly to reduce your chances of getting the HIV infection. There are also vaccines available for HPV, like mentioned before, as well as Mpox. You may be familiar with the term monkeypox as well. That was what that disease used to be called. Now it's called Mpox, but there is a vaccine available for that one as well. It is very important that you always discuss your STI status before you ever have sex with a new partner. It's also a good idea to get tested before and after you have a new partner. I know that's a lot of testing, but really it is the only way to know for sure what your status is and to make sure that everybody that you're involved with is going to stay healthy. Finally, a little bit of a note on UTIs or urinary tract infections. They are not STIs. UTIs are usually caused by just bacteria that's in the environment or on the body. A lot of the time it's E. coli. So you can get an infection in the urinary tract, in the urethra, which is the tube that pee comes out of, through bacteria getting into that area. So UTIs can be prevented through having good hygiene practices, regularly showering, keeping the area clean, as well as peeing after sex or urinating after sex, and avoiding using soaps on or in the genital region, especially for AFAB or assigned female at birth individuals. AMAB or assigned male at birth individuals or people who have a penis are able to use soaps on their genitals with usually no issue, but it's very important to avoid using any kind of harsh irritants or things like douching or vaginal soaps, because that can disrupt the kind of flora and fauna or the pH of that region, which can actually cause UTIs as well. Switching gears to talk about another huge part of sexual health and safety, birth control. Birth control is all methods of contraception or things that a person can use or do to reduce the chances of an unplanned pregnancy occurring. Pregnancy is a possibility for any pair of people where one person is assigned male at birth and the other person is assigned female at birth. So of course this is not just cisgender men having sex with cisgender women. This can include trans people, gender nonconforming people, non-binary people, or pairings of cis people with people of these other identities as well. The reason for this is all that it takes for a pregnancy to occur is the meeting of a sperm and an egg, the types of gametes that are produced by AMAB and AFAB bodies. So if you have that kind of relationship pairing with your sexual partners, then birth control is something that you're probably going to want to be thinking about. There are a lot of barrier methods that can be used, like condoms. They can be very helpful. They are about 98% effective if they're used completely perfectly, and about 85% effective if used without any other methods. So just one condom and no other type of birth control in the picture. It's very important when using barrier methods that if you're using condoms, you don't ever want to use more than one condom at the same time. Sometimes people think that putting one condom over another will help with creating extra barrier, but actually that can increase the friction between both and then lead to the chances of one or both of them breaking being a little bit higher. It's also important, and this again, there's a lot of misconceptions about these things, that you do not want to use the pull-out method if you're using condoms. That can lead the condom to come off, and then that kind of defeats the entire purpose. So using the pull-out method in combination with condoms, even though it seems a little counterintuitive, it will actually most likely, if that condom is intact, be the safer way to go. Finally, condoms do work the best when they're paired with another method of birth control. So that could be a lot of different things that we'll discuss on the next slide, but a lot of the time people will use some kind of hormonal birth control in combination with barrier methods such as condoms, and that combination is one of the most effective types of birth control, or more effective. There are a lot of other kinds of birth control methods. Hormonal birth control can be things like oral contraceptives, or you'll hear people call this the pill. There's also Depo-Provera shots, which sometimes people will just call the shot. Both of those cases is going to be a either daily dose or a large dose of hormones that kind of trick an AFAB body into believing that that person is pregnant, and then it stops ovulation, which is the process of an egg exiting the ovary and going into the uterus to prepare for pregnancy. There are also IUDs, intrauterine devices, which can be used. These can be hormonal or non-hormonal. There is also the patch. This is just a skin patch that lets hormones into the body through the skin. The implant is a small device that, again, also lets out hormones into the body, but it's implanted underneath the skin. And there are also Plan B pills, which are a type of contraceptive a person can take if they're not taking, say any kind of other hormonal birth control, and they have unprotected or barrier-free sex with someone, and they might be worried about possible pregnancy. A Plan B pill is kind of like a whole bunch of oral contraceptives in one. There's also a lot of non-hormonal options, so people can use things like spermicide, which is sometimes a lubricant, sometimes a foam that can kill sperm cells. Condoms, which we just discussed a little bit. Diaphragms, which are very similar to condoms as far as the material they're made of. They're usually kind of like a square sheet of latex or polyurethane that can be used for oral sex or other activities to prevent that swapping of fluids, as well as fertility tracking and the pull-out method. These are not very effective, but a lot of people like to combine fertility tracking with the pull-out method, with spermicide, with oral contraceptives, or some other combination of a bunch of different methods. And the more methods you have, as long as they're not kind of contradicting each other, the less likely an unplanned pregnancy is to occur. There are also more permanent forms of birth control. There is something called sterilization. For people who have testicles, you can get something called a vasectomy. This is essentially just the snipping or the closing off of the vas deferens, which is the tube that brings sperm from the testicles out of the penis. Often vasectomies are reversible, and a lot of the time they are covered 100% by insurance companies. So if that's something that a person is interested in, you would want to get in contact with a urologist to kind of go down that route. There are also tubal ligations, which is when you hear someone saying getting their tubes tied, that is a tubal ligation. Or bilateral salpingectomies are where a person gets their tubes removed for anyone who has a uterus. Tubal ligations, or getting your tubes tied, that is reversible. But bilateral salpingectomies, the complete removal of the uterine tubes, that is not reversible. A lot of the time, bilateral salpingectomies are covered by insurance because they're considered preventative care. A lot of uterine cancers do start in the uterine tubes, and so removal of those tubes can decrease a person's risk for those cancers. So a lot of insurance might cover that procedure as well. Unfortunately, for those who do want these procedures, they can be difficult to access. We see a lot of change in legislation across the United States regarding these kinds of procedures, but there's also a gendered element to these procedures. For AFAB people and for women, getting tubal ligations or bilateral salpingectomies, or bisalps is another way that we could describe those. There's a lot of stigma about not wanting to be a parent, or stigma towards child-free, or people who do not want children. And so it can be difficult to access these kinds of treatments or these kinds of procedures, but there are a lot of resources. If anyone's interested in learning more about this, I can get you connected with some resources on this topic as well if you want to email me about that. You can also Google about it. There's a lot of resources online accessing these kinds of procedures. Closely related to our discussion of birth control is the topic of abortion. Abortion is the deliberate termination of a pregnancy. There are medical or medication abortions as well as surgical abortions. And the medicines that are used for a medication abortion, they are very well studied. They're actually very safe for an individual to take, safer than taking Tylenol. So medical technology has come a long way in that arena. Luckily, it makes these procedures fairly safe, at least for the physical body, for any individual who is going through this experience. And for anyone who takes these medications for a medical abortion, the effects of those medications are actually indistinguishable from a naturally occurring miscarriage. So when we see a lot of legislation changing in particularly southern states in the United States, this is good information to know if a person ever finds themselves in a situation where they are considering or looking to do a medication abortion. It is important to know that those are actually very safe medications, and the effects of those medications look exactly the same on a medical context from a naturally occurring miscarriage. There's a lot of research on the topic of abortion, and across the board what that research is showing us is that access to safe and effective abortions, this can prevent a lot of different terrible things. So access to abortion prevents pregnancy complications, deaths, interpersonal violence, especially towards pregnant individuals, prevents unsafe abortions, the entrapment of pregnant people in unsafe relationships, poverty and job loss, mental health problems, and so much more. So I know this is a political talking point for a lot of people. This is a very difficult conversation. This is a very hot topic, and so this can be very difficult to learn about, and I know not everybody will agree with what medical sociological research is telling us about this topic, but medical sociologists and the research are pointing towards the belief that abortion is a very important part of healthcare. Because abortion is such a politicized and inflammatory topic in recent years and recent decades, there is a lot of misinformation about abortion. So sociologists are super interested in how this misinformation is created, how it spreads, and why we have these kinds of myths bouncing around in our society. Who benefits from those, those misinformational PSAs and these kinds of myths? What is the purpose of spreading that kind of misinformation? Definitely something we're thinking about. A couple myths that I want to kind of bust here. Late-term abortions are something that only happens when a fetus or the pregnant person will be gravely harmed or will die if that pregnancy progresses. Typically, abortions are done before the 24-week mark of pregnancy. Late-term abortions are not a very common thing. When they do happen, it is because lives are at stake. We also know from the research that science just really doesn't support the idea that life begins at conception. This is something that we hear a lot. It's a very big talking point on a lot of conservative talk shows or in different religious spaces, but the biology just really doesn't line up with that idea. A fetus is not viable, meaning not able to live outside of the parent until 24 weeks. 90% of abortions happen before 12 weeks. So there's a long period of time before a fetus becomes viable, and I guess we could debate about what the definition of life is, but I think it's very important that we look at those statistics and see that the vast majority of abortions are happening very early on in a pregnancy. We also, of course, know from the research that criminalizing abortion just leads to people seeking unsafe abortions, but actually no decrease whatsoever in abortion rates. So abortions will continue to happen regardless of what the legislation looks like, but people who are seeking unsafe abortions, or if abortion is not safe and accessible, then people are in this situation where they're going to seek that abortion anyway, but it's going to be a lot less safe for them. If you or anybody that you know does need an abortion, there is this website, plancpills.org, that you can visit to access a medication abortion or to access the medication for a medication abortion, especially if any of you all are out of state. In Colorado, we have a lot more protection through our legislation for abortion, but if you or anyone you know is in a situation where you cannot easily access this kind of treatment, that is a useful website to check out. So sexual health and sexuality, sexual orientation, and medical sociology's overlap with sexuality is a huge topic. We really just cannot cover this entire topic in 1 week. We really can't cover this even in an entire course. There are 16-week courses that go over this topic, and it is really just that massive. So a lot of things that we could have discussed this week would also be things like polyamory, polysexuality, non-monogamy, monogamish relationships, relationship anarchy. There are a lot of other relationship styles, and we really just didn't get to jump into that topic very much this week. So I encourage you to look into that yourself if you're interested, or feel free to reach out if you have any questions or if you want to learn more about those topics. We also didn't really get to cover this week cultural and national differences in attitudes about sexuality. We talked quite a bit about the United States perspective, but of course around the world there are a lot of differences in how people are going about their lives, what people's sex lives look like, what different identities people have in different areas, and the level of acceptance of those behaviors and identities. And we didn't really spend a lot of time looking into the sexual behaviors of people from different communities or identities. So we could look at the sex lives of disabled people, queer people, different religious groups, gender nonconforming people, and so on. We touched on this a tiny bit this week, but we'll actually talk about this quite a bit more as we move forward in the class. There's going to be intersections of the discussion of sexuality and sexual health throughout the rest of the semester. But really, there are just so many things that we could cover with this topic. I am super happy to expand on anything in this lecture or to have discussions about this topic. Sexuality is one of my main research focuses, so this is kind of one of my favorite, weeks to talk about this content, and I'm happy to answer any questions. If you do have any questions you're not comfortable asking with your name attached, like through an email, please use that anonymous form on the homepage of Canvas, or I believe it was posted last week in the module for this week. Feel free to reach out with any questions there or over email or wherever you're the most comfortable. Thank you all for being here for this lecture this week. I'll see you next time.